Hi, Emma.
Hi, Jonathan.
It's time for
Cut
Cut
to
to
the
the
case.
Case. And Emma, you've got a case.
Yeah, I've got
Yeah.
a good and interesting case.
All right. Tell us
So
what happened.
I came to an emergency buzzer in our resuscitation area of our emergency department.
Not an unfrequent event in our department, especially at the moment.
Yeah,
Yeah.
and found an elderly gentleman having a seizure.
Okay.
But what was
Yeah.
interesting is he was already on monitoring. He'd been handed over. He was on the bed.
Yeah.
But there was only a blip. Pause. Blip.
Oh,
Pause. Blip.
like the
So
monitoring's not on?
no, the
Or
monitoring's on, but every now and again he'd have a QRS complex, so he's very bradycardic.
he's having a seizure, but he's bradycardic.
Yeah, that's right. So what are you thinking about?
I'm actually thinking, Emma, he's not having a seizure. He's having a hypoxic seizure.
That's
So
right.
he's not
Yep.
having an
Yeah.
epileptic seizure. It sounds like he's actually hypoxic, and that's why he's twitching. Is that what it was?
Yeah,
Is
so
that
lack
what
of
you're
blood
saying?
flow to the brain.
Yeah,
So
okay.
the underlying cause was a complete heart block,
Well,
so and a profound bradycardia.
So, and he's on the monitor,
He's
but
on the
you
monitor.
kind of didn't know that. So you've
No,
come
no,
to,
there's no one attending, and so
he's been brought in by the
Yeah,
ambulance, and he's
yeah.
having seizures and got it, and he's profoundly bradycardic.
yeah.
Well, hell, well, let's talk pacing. Let's talk
Yeah,
bradycardia.
Yeah. So the tricky thing was for him, he'd arrived, we noticed he had no IV access.
Okay.
And we've got an elderly man fitting with a presumed complete heart block. So we rapidly assembled a team with our nursing staff,
Yep.
and a couple of doctors arrived. And then,
Imagine.
then it's really negotiating, what do you do first when you have no IV access? So there's a couple of things that you can do.
Well,
What are you thinking?
You need to speed him up. I mean, this
Yep.
is the thing. He needs to speed up. He's not perfusing his brain. That's why he's seizing. So
Yep.
usually I'll be reaching for adrenaline. I'll be wanting to speed him up. So I would chemically speed him up. I'd chemically pace him. I'd get some adrenaline drawn up.
Yeah.
And I'd use a push dose presser kind of dose, boluses of mics of adrenaline to speed him up. So let's do it. Let's just speed him up, Emma.
Well, the problem is he had no IV access. So what do you
get access?
Okay, what are your options and how long do they
Get
take?
the access.
Okay, so put on a tourniquet, get an intravenous line.
You're saying
Yep.
it's going to take too long.
Yeah, well, it might do.
Well, how
One
long
of the
did it
other
take you?
options is are
Are you saying it took your team a while
just
to get
shush for a
access?
second. So it's an option, and then the second option is getting interosseous access.
IO.
Yeah, and they're both valid.
Yeah.
They're both great.
So just take me through. So because this is really important, right? And it's a real barrier. So you've got people working on both arms to get IV access. How long do you give them?
Well, you want it pretty instantaneously, don't you? So, but the point is, with this particular case, we had a number of people able to start interventions. So what we did is concurrent interventions. So we had someone putting in IV access.
We're going to get the IO in case we can't get it.
Yes.
Yeah.
And then on the left-hand side of the bed, there was another intervention that we could use.
Would that have anything to do with that thing behind us?
Yeah, that's
like
right.
The defibrillator and the pacer?
Yeah. So,
okay.
So, you've got the ability to do chemical pacing, but also electrical pacing. So
what did you actually do? Did you wait until the access went in and you got some adrenaline in to speed him up to recover, or
no,
did you go for?
We did lots of things concurrently.
Okay,
so while there was someone tasked to putting in IV access in the right upper limb, we actually went ahead and put the pads on the chest, and we started pacing, electrical pacing.
All right. So pacing is one of those things. Look, personally, we practice it, but we don't do it that much.
Yeah,
we don't do it that often. Yeah. Any tips?
Yeah, well, first you need to turn on your machine and move it to pacer mode.
I got that bit.
Yeah.
Turn it on. But you're right. And remember, some defibs, you probably remember because you're old, but some defibs didn't actually have the pacer module in. Remember, there wasn't a pacer module in some defibs. Most defibs have it now. So some of them didn't have the pacer.
Yep.
So turn it, and you don't just turn it on, you turn it to pacing.
Pacing.
Turn to
That's
pacing
right.
mode.
Pacing. Yep. And now the method we used for our pacing was anterior and lateral. He's laying there seizing, so we really needed to do that.
And his
seizures were only.
You've got him on his side, I suppose.
Well, his seizures were short-lived actually, so they were intermittent seizures. And actually, within seconds, and I'm talking sort of 20 seconds, we began pacing him.
Really?
Yeah, it was
Slick
really
team.
very slick team.
Okay.
So now just to go through the steps, so you need monitoring, you need your pacing, you can choose anterior and lateral, you can choose AP. It suited us to do anterior lateral. We then set the rate, and we set the rate at between 78 80 beats per minute. And then you dial up the output, your milliamps. And we got capture at about 70 milliamps, and there was electrical capture, so you could see the spikes on the pacing machine, but we also had mechanical capture. You could feel a pulse, but actually we didn't even need that. He stopped fitting and he sat up and he's like, hello.
I just want to take you to task on one thing, the monitoring.
Yes.
This is something that I've had some issues with in the past. What do you actually mean, the monitoring in this thing?
So you've got a 3-lead monitor.
So yeah, this is a key thing. So normally you put the pads on and you can read the rhythm and you can defib through the pads, and that turn to pads. But when you pace, and here's the trick, and this is why I'm emphasizing this, the pads on. But you need 3 leads on the patient. And that's the monitoring. That goes into the back of the pacer, and then the output goes through the pads.
That's right.
So you need 2 things on.
Set the rate,
and pads.
dial up the output in milliamps, and we got capture at about 70. Electrical capture, you could see the spikes, and then mechanical capture, you could feel the pulse. But actually, like I said, he sat up and began interacting with us, and actually was relatively comfortable, despite the pacing.
The jolts. So did you have to analgesia and sedation, or was it okay?
So yes, but at the same time we gained IV access and we were able to start some other interventions. So we left the pacer going, we got some adrenaline, we had an adrenaline infusion up and started, and then we actually turned down the milliamps, and he was chemically paced and he was very safe.
So in summary,
we came across an unexpected patient who was seizing, but seizures weren't the main issue. The main issue was profoundly bradycardic. And then we had a number of interventions, but we had a number of people there to help. So we were able to try and gain IV access. At the same time, we were able to place pacing pads on and go through the pacing algorithm, which is pacing pads on, monitoring on, put onto pacing mode, set the rate, and then dial up the
electrical capture, mechanical capture. Patient wakes up, off to the cath lab. That all sounds beautiful. But I'm sure there was more to it, Emma. And let's get to that in part 2. How you manage a team when you've got to do so many actions all at once.
And I think that's why it was so successful, is we were able to label what was going on, establish our team, make a brief assessment of what was going on, and then direct what are we doing as our first task.
Sounds to me like you're talking about leads.
We'll talk about that next time.
More on that next time. See ya.